A very good morning to one and all. Welcome to the monthly meet of the Association of Physicians of India API Trichy chapter. We'll start initially with the Tamil Thai Varthu followed by the prayer song. Physician's prayer. Dear Lord, thou great physician, I kneel before thee, since every good and perfect gift must come from thee. I pray that you give skill to my hand, clear vision to my heart, and strength to my body. I pray that I will always realize that being a physician is a privilege and honor. With the simple faith of a child, I will rely on thee. Thank you. I now request the API President of Trichy branch, Dr. Ravi sir, to welcome the gathering.
I have great pleasure in welcoming all the members of API, members from other faculties, and then Dr. Harishankar, Chief Consultant and Head of the Nuclear Medicine Department, Meenakshi Mission Hospital, Madurai, who is going to deliver a lecture on nuclear medicine, how can it help a practicing physician, and Dr. Manivannan, founder and managing director of Kaveri Hospital. He is going to deliver a lecture on healthcare lessons learned from 2020, which is very important in our aspect. We welcome you both for the important meeting today. Welcome one and all again. Thank you.
Thank you, sir. Minutes of the previous meet. The previous meet was held on January 31st, 2020, and we had two speakers. This was the first time we got CMA accreditation as well from January 2021. And the first speaker was Dr. Lakshmi Kandasamy ma'am, Professor, Department of Microbiology, and the ma'am spoke on COVID vaccination and update. And the second talk was by Dr. Bhuvaneshwaran, Director of PSG Super Specialty Hospital, on what is not taught in medical school. It was well attended and appreciated. Around 60 people attended the meeting. Coming to today's speakers, may I have the honor of introducing the first speaker of the day. The first speaker of the day today is going to be Dr. CNB Hari Shankar, a dear friend of mine. Hari did his MBBS from Stanley Medical College, Chennai, and then went on to do his MD in nuclear medicine from PGI Chandigarh. He currently is a head of the department and senior consultant in the Department of Nuclear Medicine, Madurai Meenakshi Mission Hospital. He's a recipient of around 20 gold medals and prizes during MBBS, including the best outgoing student and the most deserving student award of his batch. and is a silver medalist for research activities at PGI Chandigarh as well. Dr. Harishankar has more than 50 indexed publications in various international and Indian journals, and he has delivered several guest lectures and presented papers both nationally and internationally. He is in the editorial board of the Indian Journal of Nuclear Medicine and was conferred membership in the Indian College of Nuclear Medicine in 2013. He is also a fellow of the Asian Nuclear Medicine Board and the European Association of Nuclear Medicine. We have the privilege and honor of hosting Dr. Harishankar today.
Thank you, sir. Thank you for the kind introduction.
Hari, are you able to share your screen? Yeah. So the first topic, ladies and gentlemen, is going to be on nuclear medicine. How can it help the practicing physician?
So before I start, I'd like to thank the APA of Trichy branch for giving me this opportunity. A special thanks to Dr. Sakthi sir for inviting me for this. So this is a very general talk. It's both the easiest talk to make in nuclear medicine and also the most difficult one, because we don't know how to cover the entire spectrum in 30 minutes. I'll try to do justice by contributing as much as I can. This talk is directed to the general physicians. Sir, am I audible, sir? You are.
Yeah, I'm Hari. I'm muting all the participants. You can unmute yourself. Yeah, you can unmute yourself, Hari. Yeah.
Am I audible now, sir?
Yes, yes. Yes, Hari, you can go ahead.
I'd like to thank the API Trichy branch for giving me this opportunity. Special thanks to Dr. Sakthi. So I'm going to target this talk only to the general physicians. I'm not going into the deep oncology side of the role of nuclear medicine. So we all know nuclear medicine and radiology are two diagnostic branches. The main difference being that nuclear medicine, we use radioactive isotopes. So radioactive isotopes are injected into the patient's body and the patient is made radioactive. While in radiology, the equipment is radioactive. The CT scan is radioactive and X-ray machine is radioactive. So radiation is passed through the patient and then images obtained.
Hari, 1 minute. There's some annotation problem. I think it's in your screen, Hari. You need to go up and then press that option where there comes something called annotate. ANNOTATE. Annotate.
I'll clear it.
Yeah, you clear it.
I think some okay. Now it is clear.
Yeah, it's clear, Hari.
Okay. So basically, radiology is transmission image, where where a radiation source produces the X-rays. It passes through the patient, and then the imaging instrument will image the transmitted X-rays. But in nuclear medicine, it is basically the emission image, where the patient is radioactive and the patient emits radiation. We have equipment which will detect the radiation. So the basic difference being radiology is an anatomical imaging, while nuclear medicine is functional imaging. So this is a slide which will show you the difference between the basic difference between two imaging specialties. See, in radiology, you can see the thyroid, but does not give you any information as to how it is functioning. While the nuclear medicine image shows how the thyroid is functioning. Well, similarly, you can see the kidneys in CT, but we don't know how it is functioning. While the nuclear medicine imaging shows how the kidney is functioning. But this difference has got blurred. Now it's the time of fusion imaging. You can see the CT scan, which gives you the anatomical image, the PET scan or SPECT scan, which gives the functional image. In this case, the cloud morphology and the cloud position the different parts of the area. When we fuse both together, we get much better information. We have both the anatomy and also the functional status. So now most of the departments are using fusion imaging. So coming to the basics of nuclear medicine, the basic workhorse of nuclear medicine are radioactive isotopes, which include the technetium-99 and iodine-131 in nuclear medicine department, while fluorodeoxyglucose and gallium-68 in the PET department. So this is our gamma camera, and this is our PET CT. So I'll present it in different scenarios to make it a little interesting. So coming to the first scenario, a 23-year-old unmarried girl, recent onset weight loss of 5 kgs in 2 months. She has dyspnea on exertion and palpitations. She has tremors. Her eyes are prominent. On examination, there is no obvious goiter. She has sinus tachycardia and fine tremors. So investigation done shows both total and free T3 and T4 elevated, and TSH is suppressed. So this is a scenario which almost every practicing physician will encounter in his practice. So the basic two differential diagnoses in this presentation includes Graves' disease and thyroiditis. So Graves' disease is overproduction, and thyroiditis is destruction and release of stored hormones. How do we differentiate this? This can be done very easily with the help of a technetium thyroid scan. So this is technetium thyroid scan. You can see here in this patient, there is intense uptake in both lobes of thyroid which are enlarged. The technetium uptake is around 25%, which is significantly more than the normal limits. You can see rest of the body, there is no tracer. All the tracer has been taken up by the thyroid. This indicates that thyroid is hyperfunctioning. While in thyroiditis, because the thyroid is destroyed, the function is completely lost. So there is no uptake in the region of the thyroid. These are the salivary glands. So this is a very simple investigation which can differentiate between Graves' disease and thyroiditis, basically by studying the functional aspect. No other investigation will be able to identify this difference. So other roles in thyroid diseases include a patient with nodule and suppressed TSH. You can see here this patient, he has a large goiter with multiple cold areas and also areas of increased uptake. So this is actually a case of a toxic multinodular goiter. While in this patient who had clinically a single swelling in the right lobe of thyroid, so you can see this is the perfusion images. The nodule shows increased perfusion, and on this image you can see that the nodule is showing increased function, indicating that it is a functioning, autonomously functioning thyroid nodule. So this type of presentation, which all of you must have encountered, young boy with a swelling in the upper part of the neck. So we don't know whether this is a thyroidal swelling, whether it has thyroid tissue or not. So this is the thyroid scan for the same patient. You can see there is no uptake in the region of the thyroid gland. There is only one focal uptake in the upper part of the neck, which is corresponding to the swelling, indicating that this is the only functioning thyroid tissue. This is the ectopic thyroid tissue with absent thyroid tissue in the normal position. This is another patient. This person also has a nodule in the upper part of the neck, but you can see that the normal thyroid is there, but there is no tracer uptake in the expected location of the swelling. So in the previous patient, if surgery is done and this is removed, the patient will become permanently hypothyroid. So this can be avoided by using functional studies. While in this patient, this cyst can be safely removed. And another role in thyroid diseases is in patients with congenital hypothyroidism. So you can see these three different patterns of congenital hypothyroidism. This is the thyroid dysharmonogenesis, where the thyroid hormone production is low, but the thyroid is showing intense uptake, indicating that there is a problem with the T3, T4 production, mainly because of some enzymatic deficiencies. The second one is ectopic thyroid in the region of the base of the tongue. This is a lingual thyroid. And this is the congenital athyriosis. So this is useful because the risk of the sibling getting the same problem is high with thyroid dysharmonogenesis. And this can also be used in other congenital anomalies of thyroid, like in positional anomalies. You can see this is a dual ectopic thyroid. There is a thyroid tissue in the base of the tongue, and there is also a thyroid tissue in the suprahyoid location. And this is multiple areas of ectopic thyroid. You can see there are three different places where ectopic thyroid tissue is found. So to identify the functional status and also to see the congenital anomalies, we can use thyroid scintigraphy. So basically, it is for identification of functional tissue, disorders of the thyroid, for the evaluation of nodules, for localizing thyroid tissue in patients with suspected ectopic thyroid tissues, and in congenital hypothyroidism, and also for determining the role of radioactive iodine therapy, which I will come later on. So coming to the second scenario, this is a 50-year-old diabetic lady. She's normotensive. She has recently diagnosed dyslipidemia, complaints of recent onset chest pain that is which is worsened by exertion but not conclusively related to physical activity. The pain is more in the central part of the chest and interscapular region, and resting ECG and echocardiography are normal. So this is basically an atypical chest pain in a young lady. So what would be the next choice of investigation? Will you go for a conventional angiography? Will you do a CT coronary angiography? Or we can go for a myocardial perfusion imaging, which where there is a we give the patient stress, make the patient do exercise and inject tracer at the maximum exercise to see the blood supply during the stress, and also do an imaging during the rest and compare the both to see whether there is difference in blood supply during stress. So this is the images. You can see the top row is after the stress imaging, the bottom row is after rest imaging. You can see this is the septum, this is the anterior wall, this is the lateral wall, and this is the inferior wall. You can see here during the stress, this lateral wall and inferior wall are showing less tracer uptake, while after in the rest image, the entire myocardium is normal. This indicates that there is a reversible perfusion defect in the lateral and inferior wall, which probably involves both RC and LCX territories. And apart from that, this myocardial perfusion scintigraphy not only shows the perfusion status, it can also show the functioning of the myocardium. You see, you can calculate the ejection fraction, you can calculate the diastolic volumes and systolic volumes. Though these are, though the diastolic volumes and systolic volumes are not very accurate, the ejection fraction is very accurate. And apart from that, this the information that is obtained has a prognostic significance. You can see in these patients with coronary problems who have normal scan, their event rate is significantly less when compared to patients who have abnormalities in the myocardial perfusion scan. And it is also known that patients who have less than 10% ischemia, they can be controlled with only medical therapy, while those having more than 10% ischemia of the LV myocardium, they are candidates for intervention. So basically, myocardial perfusion imaging has the best pickup rate in patients with intermediate risk of significant coronary artery disease. And another role of myocardial perfusion imaging and PET imaging is in identifying areas of myocardial viability. So this is a patient, a young male, 35 years old male, who had a total cutoff of LAD territory. You can see the entire LAD territory. There's anterior wall, anteroseptum. It is not showing any perfusion. These are the perfusion images. The second row is metabolic imaging. That is, we have done fluorodeoxyglucose. So in this, fluorodeoxyglucose will be picked up by ischemic myocardium, hibernating myocardium. So what is the basic principle is that a normal myocardium will use fatty acid for metabolism. But when there is a reduction in the blood supply, it starts using glucose because it is it can metabolize anaerobically also. So when there is an obstruction to the blood supply, the myocardium will switch from fatty acid metabolism to glycolytic metabolism. So what we are seeing is the fluorodeoxyglucose, which is a glucose analog, and we are seeing the glycolytic metabolism in the anterior wall. So this patient actually, despite having a total cutoff of the LAD, is still having myocardium in the LAD that is viable. So when we do revascularization, myocardium will become completely normal. So myocardial perfusion scintigraphy is useful in diagnosis and risk stratification of coronary artery disease. And one important thing is that a patient who has a normal myocardial perfusion imaging has less than 1% incidence of any hard cardiac event in the next 1 year. They say up to 3 years it is valid, but in diabetic patients it is valid for 1 year. One important thing is that it can avoid invasive procedure. Myocardial perfusion imaging can be done with only a Venflon. So no other invasive procedures will be required if the myocardial perfusion imaging is normal. And another thing is that coronary angiography does not give you the information of the functional significance of the coronary atherosclerosis. For example, if the LAD is 50% stenosis, the patient is having chest pain. We don't know whether the chest pain is because of the 50% stenosis or not, because the resting blood supply will not be affected till the stenosis up to 70 to 80%. So functional significance is not known. And if it is a slowly forming atherosclerosis, collaterals will develop. So despite having significant atherosclerosis, the collaterals will be able to give adequate blood supply. So patient having significant obstruction may not have ischemia if he has collaterals. And finally, it identifies viable hibernating and stunned myocardium after myocardial infarction, and it can identify candidates who can be benefited by revascularization. So coming to the third scenario, this is a 40-year-old male. He has renal stone disease. He had a pathological fracture recently for which he was admitted. On investigations, serum calcium is 12 milligrams, phosphorus is low, PTH is very high, ultrasound neck is normal. So this is a case of hyperparathyroidism. So we have done a sestamib scan here. You can see this is the anterior image. This is the thyroid. Thyroid also will pick up sestamib. There is a focus, it is in the upper mediastinum, which shows significant sestamib uptake. So clinically correlating, it is looking like a parathyroid adenoma, but the position is in the mediastinum. You can see this is in the anterior mediastinum. So this is another patient. You can see this is another patient. Thyroids are normal. This was a 25-year-old young male. You can see there is a lesion in the chest, but the lesion was there in the left paratracheal region. So the complicated cases, it is very easy to identify parathyroid adenomas with the sestamib scintigraphy. So sestamib scintigraphy is useful in preoperative localization because in up to 80 to 90% of the patients, the hyperparathyroidism is caused by a single parathyroid adenoma. And it is preoperative localization is very useful to avoid any failure in surgery. And now, because most of the parathyroid adenomas are single, minimally invasive parathyroid surgeries are also being attempted. And also in patients with CKD where parathyroid hyperplasia is suspected and also tertiary hyperparathyroidism is suspected, it is ideal to get a parathyroid scan done before any interventional procedure. Coming to the next scenario, this is a 25-year-old male recently recruited to the army. He has complaints of pain in the leg, which is worsened after exertion and army drills. He was evaluated by the doctor in the station, and his X-ray leg was normal. So what would you do next? So possibility is that it is a stress or insufficiency fracture, for which bone scan is extremely useful. Bone scan is extremely useful in identifying causes of pain. So this is a triphasic bone scan where we see the initial flow. You can see this is the right leg, this is the left leg. You can see there is a focus where there is increased perfusion in the left leg in the region of the left tibia. This is the blood pool image, there is increased uptake, and this is the bone image. You can see there is increased uptake in the left tibia. So this is a classical case of insufficiency or stress fracture. So this patient also had a follow-up scan after resting. You can see there is reduction in the uptake in the left tibia, indicating that rest is actually helping in the cure of this problem. Another problem which we commonly face in our OPs is pain in the heel. So this is a case of plantar fasciitis. You can see the blood pool showing increased activity in the in the region of the right calcaneum, while delayed image showing that there is an uptake in the region of the insertion of the plantar fascia to the calcaneum. This is a classical case of plantar fasciitis, and patients like this who have single focus of abnormality can actually be targeted using localized steroid therapy. Similarly, for Achilles tendinitis also, this is a very useful modality. So coming to the next scenario with bone pain, there is a 55-year-old male who has a history of low back pain. There is recent onset worsening of back pain, occasional referred pain to the legs, but there is no dermatomal pattern. X-ray is non-specific. MRI has been done. MRI shows multiple level intervertebral disc abnormalities. So we don't know which is the problem which is actually causing the pain. So I actually did my post-graduation thesis in this, in patients with chronic low back pain. So this is one of my own patients from our thesis. This is, you can see there are a few foci of uptake in the lumbar vertebra. This is a hybrid imaging. You can see this is only a functional imaging. This is a hybrid imaging. The same patient, we have done a CT scan and SPECT scan in the same equipment. We have fused the things together. So you can see there is uptake in the facet joints of the L4, L5 vertebra on the right side, which is which is also correlating with the facet joints on CT. So we have co-registered CT and SPECT images, and we have identified that the pain is actually caused by facet joint arthropathy. So this patient we had given steroid and local anesthetic infiltration, and he had significant reduction in the symptoms. So to differentiate between multiple incidental findings and one the clinically important finding, we can use scintigraphy. This is another patient who has classical intervertebral disc disease. You can see this L5-LS1 disc is showing significant degenerative changes. MRI might show degenerative changes in multiple levels, but which is the one which is clinically significant can be differentiated using a bone scan. This is a patient with osteoporosis, recent history of fall. She has pain in the back. X-ray shows multiple level vertebral compression fractures. We don't know which are the new fracture and which is the old fracture. The new fracture which is causing problems can be differentiated in the bone scan. You can see this linear, transversely linear areas of uptake. These are the areas where there is new fracture, and these are the sites of abnormalities which is actually causing the pain. This patient also has multiple rib fractures which are evidenced here. And similarly, in patients with common CRPS, that is reflexive sympathetic, we can use bone scan.
Just a minute, I'll just mute all. Yeah, you can unmute yourself.
So other routine thing that we come across in practice is that we do X-ray for some abnormality. The X-ray shows a lytic lesion or a sclerotic lesion, and the patient does not have any known primary. So what do we do next? So bone scan is one method for evaluating the entire skeleton in such scenarios. So these are two bone scans of, bone scans of different patients. This is a polyostotic fibrous dysplasia. This patient also has endocrinopathies. And this is a patient who had monostotic Paget's disease. So to screen the entire skeleton, bone scan is a good modality. And this, I think almost everybody would have seen in practice. A patient with chronic diabetes now coming with either a foot swelling or an ulcer or what looks like a fracture. So bone scan is a triphasic bone scan is an extremely useful imaging modality in evaluating those patients. This is a patient who has Charcot's foot. You can see here there's a bag of bone appearance with uptake in the involved bones. So Charcot's foot, it is very useful in both diagnosis and follow-up. So bone scan in general, it's very useful in evaluation of bone pains. This is apart from the usual metastatic workup that we do. It is very useful in differentiating incidentally noted findings to clinically significant findings. This is very important because the routine imaging like MRI or X-ray, they pick up a lot of findings, but we don't know which is the one which has to be targeted. And it's very useful in follow-up of the patients. So coming to the next scenario, this is a 65-year-old male with chronic anemia. The anemia is of chronic blood loss types. 2 local blood is positive. Endoscopy and colonoscopy is negative. And this is that is another patient who is a 1-year-old boy with history of passing blood in stools. So what investigation do we use? This is a GI bleed scan. There is a gastrointestinal bleed scan which is done using labeling of red blood cells with technetium. So these RBCs are labeled, and when it is extravasated in when there is a bleeding, this can be identified. You can see here, this is the common iliac veins. You can see there is a focus in the right iliac fossa. There is increase in the tracer uptake. And when we do a multiple imaging, you can see there is increase in the uptake, which is also moving with peristalsis. So this is a case of cecal bleed. This was actually a case of colonic angiodysplasia, which can be missed on endoscopy. So the advantage of GA bleed is that it can identify the bleed for up to 24 hours, and it can localize the site of bleed so that when an interventional procedure like embolization is planned, they can direct it to the particular artery. So that is a major advantage. This is a Meckel scan, which is done using technetium. So as we know, Meckels can harbor gastric mucosa. Gastric mucosa will take technetium and concentrate it. So this is a Meckel scan. You can see there is a focus in the right iliac fossa, which is persisting till delayed imaging, indicating that this is a ectopic, heterotopic functioning gastric mucosa, in which case, in this case, in the clinical history, it is a Meckel's diverticulum, which was confirmed at surgery. So GA bleed scan can identify bleed as low as 0.5 ml. Even 0.5 ml of bleed intraluminally can be identified. This is one of the most sensitive investigations for diagnosis of GA bleed. And it can be done even in patients with elevated renal parameters or hepatic problems. So those are not contraindications for doing the GA bleed scan. And Meckel scintigraphy is more sensitive in children than adults. So coming to the next scenario, is it okay, sir? My speed is okay, or do you want me to slow down or?
That's okay, Hari. We can go. Yeah, this is okay, so that we can have a conversation later. Yeah.
Okay. So this is a 16-year-old female with slow onset swelling of the lower limb. It started in the foot, has now progressed to up to the level of knees, something like this. So what is the investigation of choice to find out if this is a what is the basic problem? We have done a Doppler. Doppler shows normal arteries and veins of the lower limbs. So now next suspicion is a lymphatic obstruction. So for lymphatic obstruction, we do what is called as a lymphoscintigraphy. So we inject technetium labeled nanocolloid or sulfur colloid into the intradermal space, and this is what it has been done. This is the foot injection. You can see there is lymphatic channels which is going up, and this is the inguinal nodes and the pelvic nodes which is going into the retroperitoneum. So this is a lymphatic imaging. In this patient, actually both the lower limbs are affected. Left is more affected than the right side. You can see the popliteal lymph nodes here. Usually the popliteal lymph nodes are not visualized in a normal patient, but in this patient, because there is a deep lymphatic obstruction below the level of the knee, there is a rerouting through the popliteal lymphatics. So this is another patient where the right side is nearly normal, while left side there is minimal obstruction with rerouting to the popliteal lymphatics. Actually, we have done a lot of cases of lymphoscintigraphy from patients coming from Trichy district. So lymphoscintigraphy is currently only available investigation evaluating the function of the lymphatic system, and it is also useful in conditions like chylothorax or chyluria. Even post-operative in patients with lung cancer where there is a surgery and then there is a chylothorax, it is useful in identifying the site of the leak. So coming to the next scenario, which is also a very common scenario, a 40-year-old female who is obese, has a non-specific right upper quadrant pain, which is worsened by fatty meal, occasional vomiting is there. Clinical findings point to a gallbladder disease, but ultrasound shows no gallbladder or very minimal gallbladder, which is ultrasonically it is not like cholecystitis. So what do we do now? How do we know whether this gallbladder is functioning normally or not? So for this, we do a hepatobiliary scintigraphy or a HIDA scan. So you can see we have given the injection, and this is the filling up of the gallbladder. So once the gallbladder is fully filled up, we give a fatty meal. So normally, in response to fatty meal, the gallbladder should contract and eject the contents, and that is how it is supposed to function. But you can see in this patient, the ejection fraction up to 1 hour is only 25%. That means the gallbladder is not functioning properly. The lower limit of normal function is at least 35% at 1 hour. Well, you see in this patient, this is the gallbladder filling. This is in the fasting state, and after giving the meal, there is contraction and there is release of the contents. The ejection fraction is 43%. So we have something called as the cholecystopathy. Apart from having gallstone disease, there is a condition called cholecystopathy, where the function of the gallbladder is not proper, and these patients can be identified using this hepatobiliary scintigraphy. So the usage of the hepatobiliary scintigraphy will predict the resolution of symptoms after a cholecystectomy. And it is also useful in sphincter of Oddi dysfunction, which happens after cholecystectomy, where there is increased tension in the sphincter of Oddi causing problems. And it can also identify biliary gastritis, duodenogastric reflux, and in babies, in newborns with neonatal jaundice, it is useful in identifying extrahepatic biliary atresia and also in biliary obstruction. So this is the hepatobiliary scintigraphy, which can be used in some of the day-to-day practices. So coming to the next scenario, this is a patient who is presenting with a painless swelling in the neck. On palpation, it is a hard cervical lymphadenopathy. Local examination does not reveal any obvious lesions in the aerodigestive tract. So we get an FNAC from the node. It is a squamous cell carcinoma. So what do we do now? PET scan is an ideal investigation for identifying these patients with unknown primary. You can see here, this is the right cervical lymph node, a large necrotic lymph node with increased FDG uptake, and there is a focus of uptake in the vallicula on the right side, which is proven to be the primary malignancy. Similarly, you can see this is the right cervical lymph nodes in another patient, and the primary is located in the nasopharynx. So unknown primary, despite doing a triple endoscopy, we can pick up at least 1/3 of the patients. The primary can be identified using a PET scan. So PET scan's role in oncology is unparalleled. It is useful in staging, restaging, recurrence evaluation of most of the malignancies now, and it is an ideal investigation for early response assessment, adapted treatment, and also in radiation therapy planning. So coming to next scenario, this is a 68-year-old male.
Hari, we have 5 more minutes, Hari.
Okay, sir. 68-year-old male, urinary symptoms. He had inability to pass urine. Ultrasound shows prostatomegaly, and PSA level is 20. So is there a way where we can non-invasively identify whether the patient has a malignancy? This is a prostate-specific membrane antigen PET scan. You can see there is intense PSMA expression in the prostate, which is also confirmed here. So this is a case of prostatomegaly, and in patients who have negative PSMA scan, this biopsy can be avoided. So PSMA can also be used for treating the patients. If this is a metastatic prostate cancer, you can see we have given lutetium-based therapy, and then there is a response. So PSMA therapy is useful in hormone response, hormone-resistant prostate cancers. So coming to the next is a 40-year-old male with an adrenal nodule. So we don't know whether it is a functioning adrenal nodule. This is a gallium PET scan. You can see a large left adrenal nodule, which is showing intense gallium uptake. So previously we used to do MABG scan, but now we have almost replaced it with a gallium PET scan. And the most important scenario that all of you will think of PET scan is a patient who has PUO. So PUO, a PET scan is very useful. You can see the different types of findings in the vasculitis. This is the giant cell arteritis and Takayasu arteritis and polyarteritis nodosa. It is also useful in complicated infections like diabetic foot infections, infected pacemakers, orthopedic hardware infections, and also in select cases of tuberculosis. So I'll show you I'll skip some of the slides and show you some more common causes of PUO. That is, this is a case of low-grade lymphoma. You can see multiple lymph nodes here. And this is a case of pulmonary tuberculosis. You can see extrapulmonary lymph nodes are also there. And the role in tuberculosis is not only in the identification, but also in response evaluation. This was done after 8 weeks. You can see there is a complicated extrapulmonary tuberculosis with involvement of the mediastinal nodes and also the lumbar vertebrae with 8 weeks of ATT. There is favorable response. This also has been demonstrated in other studies. The previous one was our own study. This is non-MAC tuberculosis, multiple lesions, and after therapy, there is complete resolution of lesions. So in complicated infections, we can use PET scan for identifying response. So a 55-year-old male, known case of DVT, recent onset worsening of breathlessness, right heart failure on echo. So this is a ventilation perfusion scan. You can see the ventilation findings on CT. You can see the perfusion scan. This is a macro aggregated albumin scan. You can see multiple areas of perfusion defects while ventilation is preserved. This indicates that it is a chronic pulmonary thromboembolism. And most common the scans that are done in our nuclear medicine departments are for the kidneys, for identifying the ectopic kidneys, for evaluation of function of the kidneys, for obstruction. So you can see here, and one of the common indications for medical person is to identify whether it is a renovascular hypertension, which is a captopril scintigraphy. You can see here the left kidney is smaller, and this is the baseline scan. The function is around 21%. And when we give captopril and do a renogram, the function falls, the GFR falls, indicating that this is the cause of the hypertension in a patient with small kidney and a renal artery stenosis. So to identify whether this is the cause of the hypertension, we can use a captopril scintigraphy. So coming to the therapeutic role, the most commonly used indication isotope is iodine 131, and the indication is hyperthyroidism. So in patients, usually single dose is curative in up to 90%. Radioiodine is administered orally. There are extremely rare side effects. Side effects are almost unheard of. Usually the permanent hyperthyroidism is the expected and the usual result. The ideal patients for hyperradioiodine therapy would be newly diagnosed graves, no prior antithyroid drugs, smaller the size of the gland, better the results, and patients without ophthalmopathy. And ideally, the patient should also be not having any systemic effects like thyrocardia. And when we give the therapy, usually there is a starting course for 2 to 3 weeks, and by the symptoms starts improving by 1 month, and they usually achieve the euthyroid status by 3 to 4 months. And most of the patients are permanently hypothyroid by 1 year, and there is no effect on the fertility or any future risk of malignancy in these patients. So, two cases I will just show you, very interesting cases. This is a young female with non-specific body pains, recent onset worsening of symptoms at night, has developed a limp recently. She was evaluated by us by several physicians and orthopedic surgeons in Trichy. Incidentally, this patient also was from Trichy. There was no cause identified. This we did ultimately, and a nephrologist had sent for a bone scan to our center, and this was the finding. This is a case of Angelman-Camurati disease, which is a progressive diaphyseal dysplasia. So some rare cases also it is possible to diagnose using nuclear medicine techniques. And this is a 57-year-old well-educated female, wife of a veterinarian. She presented with progressive loss of vision. She has visited multiple ophthalmologists. She has changed at least 4 to 5 glasses in the last 1 year. She had inadequate vision despite the glasses. So they consulted multiple neurologists who thought the problem was there with the optic nerve and optic chiasma. They have taken 3 MRIs at 3 different places. All were reported to be normal. Ultimately, she came for a PET scan. This is the PET scan of that patient. You can see the bottom row. It shows areas where there is reduced metabolism. You can see the occipital lobes are showing significantly reduced metabolism. Some involvement of the parietal lobes are also there. So this is a classical case of posterior cortical atrophy or Benson syndrome. You can see this is the statistical parametrical mapping data. You can see the occipital lobe. It is showing less than 5 standard deviations below the normal. That indicates significant hypometabolism. So this was diagnosed as a case of Alzheimer's disease, a variant called as a Benson syndrome, which is posterior cortical atrophy. She didn't have much of dementia. She had more of a ophthalmic symptoms. So other therapeutic roles, this will be my final slide, will be in bone pain palliation, in radiosynovectomy. We also have a role in the treatment of hepatocellular carcinoma or in liver metastasis. And there is a definite role in patients with neuroendocrine tumors. We can remember Steve Jobs, who had a metastatic neuroendocrine tumor, who was there. So in patients like that, we have a role in therapy. And MIBG therapy is also useful in neuroblastomas and metastatic pheochromocytomas. And the upcoming role is in metastatic prostate cancer. So in patients who are not responding to the usual hormones, can be treated with prostate-specific membrane antigen therapy. So thank you very much. Thank you for your patient listening, and thank you for giving me this opportunity.
Thank you. Thank you so much, Hari.
Can I stop my screen share?
Yeah, you can share it. Stop it, Hari. So thanks again. Hari, we'll come back to you with the questionnaire after the second speaker is
Sure.
done with this talk. So, all right, then for the second topic of the day, I will just share my screen for now. The second speaker for today needs introduction. Anyway, The second topic is going to be on healthcare lessons learned from 2020 by none other than Dr. Manivannan Selvaraj sir, the founder and managing director of Kaveri Hospital. Sir is a trained anesthesiologist. His vision of making great healthcare affordable became a reality in 1999 when he co-founded Kaveri Hospital along with Dr. Chandrakumar sir. He has been awarded an Outstanding Anesthesiologist Award in 2010 by the Indian Society of Anesthesiology, a leading medical entrepreneur 2018 by the IMA, and is also a certified assessor in ABH. May we have the pleasure and privilege of inviting sir to today's talk. Welcome, sir.
Hi, Sakthi. Are you able to hear me?
Yes, sir. We can.
Yeah. Good morning, everyone. Very happy to see a lot of senior people being here. And after a very long time, I had an opportunity to listen to a clinical lecture, actually. It's the last 10 years, I'm not practicing medicine, active clinical medicine. So I haven't attended clinical seminars, but it's very interesting to see Dr. Hari talking about various case scenarios which they diagnosed with PET-CT scan. Thank you for this opportunity. Shall I share the screen?
Yes, sir, you can share it, sir.
Just a minute, it's taking some time.
Yeah, no problem.
Are you able to see this?
Yes, sir, but I think the logo is going beyond the screen. Yeah.
Okay, sorry, man. This is the first time I'm sharing it. No problem. No problem. Right.
Can you reduce? Yeah, now it's better, sir.
So once again, good morning, everyone. Say 2020 has been a very interesting year for all of us. Every new year, we started with a lot of hopes and excitement. And by middle of March, it becomes very traumatic, actually. When sudden lockdown, sudden disruption of our regular work, so many things happened which we didn't expect. And there was a lot of uncertainty was there. And then slowly things, we started getting clear picture, and we started getting to know about the disease, management of the disease. Then we started worrying about what's going to happen to our near dear ones, what's going to happen to our near dear ones. And then we started learning how to manage things, actually. Started learning how to manage things. Okay, so it became a very bad year. Started with a good year, became a bad year, and later it turned out to be very interesting year, actually. See, what happens is initial apprehension started slowly evolving, and later we started thinking that yes, we learned a lot in this year. It's a once in a lifetime opportunity for any medical professional to be a part of a pandemic. Imagine the last pandemic was in 1920 or so. We read it in books, but we never had an opportunity to be there and an active participant, actually. So it was an exciting year. Today, what I'm going to share is personal experience about what I learned or Kaveri learned in this experience, but it may be similar to most of you, or I haven't experienced the much pains about the smaller hospitals. I may be talking on my hospital angle or my personal angle. Let's see if it is relevant to everyone, actually. Okay. So to begin with, this image we'll never forget. In 2001, when 9/11 happened and Twin Towers were hit by 2 airplanes, the most important thing is, till then America was thinking that it is invincible. Nothing can happen to America. And so no one can do anything to us. Suddenly, this was there on all the TV screens. I was there watching the screen, live action, when the buildings collapsed and so many things happened, actually. The year after this, in our Indian Society of Anesthesiologists, Trichy City branch, we organized a one-day seminar on expect the unexpected, actually. Why expect the unexpected, actually? Because America never expected this to happen in their soil. They thought they were the superpower, they could control everything, actually. A small group of radicals could change the whole history of America and the entire world, actually. So why we did this, this was the theme of the topic. We did this in Hotel Sangam. They entered such a big screen. We played this video. The first video was this, the plane crashing with all the noise and sound and all these things. In anesthesia, if you see, commonly we say is anesthesia practice is 99% boredom and 1% of panic. If you see a normal anesthetist practice, most of the time he induces the case, gives epidural or spinal, sits on the bedside, watches the monitor, watches some videos on the mobile or reads some paper or something. 99% is very boring, actually. Suddenly there will be a hypotension, cardiac arrest, or not recovery, difficult airway. So it is 99% panic and 99% boredom and 1% panic. But for that 1% panic, 99% of the time has to be mentally alert, actually. Though you may people may look like doing something else, but mentally people will be occupied that something can happen. This was taught to us in anesthesia curriculum in the postgraduate period, why we have to be always alert, expect the unexpected, actually. In that particular seminar, we were discussing about various accidents or unexpected things which can happen inside theater, how we can prevent it. Now, how we to tackle it is one thing. How do you prevent is something which we talk about in that particular seminar in 2002 in Trichy Anesthesia Society. The same thing is what happened in the COVID pandemic, actually. Basically, this is something which the world failed to predict, except for a few people like Bill Gates who predicted that few years back. You must have seen the videos which is there online. Few years back itself, he has clearly said that the important problem this world is facing is not the nuclear or terrorist problem. It's a respiratory pathogen which is going to kill many people. We are not prepared. So the countries like America or big powers were all prepared to tackle nuclear arm race or space race. So many things they were ready, but this minuscule virus just shook their confidence, actually. So the most important lesson which we have learned is it is very prudent and very cost effective to be proactive than reactive, actually. See, reactive is something which we act after things come, actually. Okay. If you take America, America was not ready for the pandemic. They have to beg, borrow all the masks, ordinary masks, in front of public, international media. It was a shame, actually. They didn't have manufacturing facility. They don't have anything. They were not prepared. And people were not educated. There was chaos among the states. If you take Indian states, at least there was a lot of harmony when compared to America. So every state reacted in a different way, and it is pathetic. And now we see what happened to the US, actually. Rather, certain countries like South Korea or New Zealand or other countries were very proactive earlier itself. Hong Kong or Taiwan, all these countries had SARS epidemic, and they were ready and they knew how to manage the pandemic, and they did very well, actually. If you take our own states, Kerala was very proactive because they already had a small epidemic, and then they were all prepared, well prepared. But unfortunately, now their numbers are increasing. That's a different reason altogether. So in such kind of a pandemics or any other crisis, being proactive is a very prudent and sensible, actually. So how do you be proactive, actually? How do you know what's going to come? These are some things which very rare, very few people in the world predicted. So we can't predict things. So how do you be proactive? Proactiveness within the organization. We have to be proactive in many things. For example, the financial prudence, actually. This pandemic has taught that even big companies who are doing extremely well beforehand, for example, the airline industries or hotel industries, they all struggled. A lot of small online companies, they all struggled, shut shop, actually. So financial prudence, people think that, yes, this year I got a lot of money, I saved money, okay, I can spend it next year. But that's not right, actually. Probably we need to have a good cash reserve in our organization or a small hospital or personally. A cash reserve is very, very important. For that, we have to be proactive. We should not be thinking about next month or next few months or next year or two. We should start thinking about what is my short-term, medium goal and the long-term goals of my personal goals and as well as company goals. And based on the goals, we have to be proactively, we have to put in certain action points there. For example, here, what happened? What we did was, way back, every week we have a general call with all the medical administrators of all the 7 hospitals. That practice, we were having it in the last 2-3 years. And every week they used to have nice interaction. They always keep talking, sharing their experience that this happened for me, this particular complication we saw, this patient complication. We all learn from each other. In January 18th or 19th of last year, one of the medical administrators was taking up this topic and said that, so something is happening in China, we all read it. So I said that, no, I think Chinese are known for all these kind of viruses, it will not come. So he said that he was an ex-Navy man. He said very clearly, no, sir, I think the world will get affected. He was the only one who said that this is going to impact everyone. So we were not bothered. So what we said, okay, every week we'll track this pandemic. We were tracking this pandemic every day and every week we were interacting. Then from February 10th onwards, we started talking daily. Actually, daily, all of us started talking what's happening. And everyone shared their experience of, some people had friends in China, US, UK, and everyone, and they spoke to them and they started discussing how we can tackle it. So we started stocking all the masks and other things, but we thought it will not be so severe. We had around 5,000 to 10,000 N95 masks at that point of time. It's by February middle. At that time, it was costing us 35 rupees, and it went to up to 150 rupees in next 1 month. But we were stocking all those things. In fact, aprons or so many things we were stocking. We started giving hand rubs to all the patients. Everyone started asking why you are giving. The public were not aware about it. We were a bit proactive. Then we spoke. I had a personal talk with my financial officer, chief financial officer. What I thought that the lockdown may come. So I thought, what if lockdown comes, patients are not going to come to our hospital, what are we going to do? So he gave me around 5 points of agenda where we'll cut down all these expenses, where we'll maintain other expenses. So like that, we took some proactive measures. But this happened in just 1 or 2 months before the pandemic really impacted us. But what I'm talking about is a proactive measures which is taken years before something is going to hit you. Years before. How we are going to build the team and other things, which I'm going to come. So the most important lesson for everyone is proactiveness than reactiveness is very important, actually. See, what we say is, for any problem or any argument, we say you should not respond, you should not react, and you should be proactive. So that is a different discussion altogether. So the next point is, credibility is the most important thing in healthcare industry. A lot of people think that, okay, I have a big equipment, I have this, I have a lot of other infrastructure, that is enough. No, credibility is the most important point in this whole industry, healthcare industry, which we saw. Personally, we saw patients trusted us. They admitted their parents. They couldn't see the parents. They spent a lot of money. Many times parents died. They still accepted, took the body. 99% of the time, there was not any problem. They trusted us because of the credibility, which we established over a period of time. They said that, okay, fine, we know you. We have been treating in this hospital for a long time. So we are credible. We are, just a minute. We are a credible organization. So those things we established over a period of time. Since we established all those things, so people trusted us and came to us, actually. That was a very important thing. And when people trusted us and came to us, it is our duty to improve the trust, not erode the trust. That is very important. Initially, many hospitals were a bit worried about treating COVID patients because they didn't have infrastructure, they didn't have adequate team members, or their staffs were not trained, or they haven't already handled such kind of an epidemic or pandemic. So they were hesitant. We are one of the very few hospitals in the state to admit. In Chennai, we were the first one to admit. In Trichy, Salem, Hosur, wherever, we were the first one to admit COVID cases, actually. Then there was a lot of discussions. We used to keep tracking the cost to the patient even before COVID. It's not last 10 years. We have a robust cost control mechanism where we track how much patients are spending, why patients are spending more, can we reduce the cost, all those things we have been tracking for a very long time. We had a robust IT systems which helps us to do this. So I personally started tracking how much a COVID patient started spending. Then slowly we cut down the cost, unwanted investigation. Do you really need this investigation? Do you really need tocilizumab or all these costly injections? We started cutting down on investigations and medicines. Patients were willing to spend, but we were not willing to do unnecessary spends. Then what happened? Government came with the tariff because they found that some of the players were charging more, and government came up with the tariff system. Actually, tariff system came at the time, when tariff system came, we immediately followed because the tariff was a bit higher, 10% more than what we were already charging to the patient. Actually, so we immediately adhered to the government tariff, except for few patients, like patients who had plasma therapy or high-end drugs, which patients were willing to pay, and we got consent. Otherwise, 90% of our patients, we adhered to the government tariff. This helped us to ward off all the problems. Say a lot of sting operations happened with the media. They went and asked, how much do you charge, and all those things. Even that sting operation, our hospital guy was telling that, no, normally it is 10 to 15,000 is what average cost or maximum cost. So we were able to avoid the bad press because we had already established a protocol and process that include clinical protocol or tariff systems and other things, actually. So we ensured that credibility is maintained and people trusted us, actually. So this helped us to tackle problems, because a lot of mortality was there in the initial period, and that helped us to tide over that crisis. The another important thing is the lessons taught to all the healthcare organization. People are the biggest asset for any organization. And here all of us realize that nurses are the pillars in the organization. Many times it really upsets me, surprises me, why someone like a quality manager in the hospital gets 50,000 rupees, 60,000 rupees salary, but a well-qualified ICU nurse gets not more than 30,000 rupees. Managers get more in non-medical areas, but nurses are not getting more. Or we are ready to spend lakhs and lakhs of money to pay for a doctor, one doctor, but we are not ready to pay 15,000 or 20,000 for an experienced nurse. But believe me, the nurses are real angels, actually. Not only nurses, everyone, but very particular about the nurses, because the last 20 years, since I'm a critical care physician and anesthetist, I've been passionately training all my nurses, both in ICU, theater, and emergency. I've been training them to intubate, ventilate, and whatnot. I've taught them everything. And since I'm an NABH assessor, whenever I go to assess a hospital, I come back, I teach these nurses about quality. I made few of them as a local assessor, few of our doctors, including Dr. Sendil Kumar, anesthetist, is a NABH assessor. And we trained them, we reskilled them, and all those things. In fact, we were very particular that the nurse's salary has to be at par or above whatever local players are. And we had a lot of training programs, all the benefits for the nurses, maternity benefits, you name it, health benefits, everything was there. And in fact, last year we increased the salary significantly. It was a market correction which we did for the nurses, actually. And we found that that worked very well for us, very well for us. In fact, when first few days when I walked into the hospital, the nurses said, "Doctor, why you are coming? You need not come. We will take care." I said, I just asked, "Are you not afraid about this virus?" "No, sir, we are not afraid. We know that we have been very rigid. We have had rigid protocols already there for all these infectious disease. We can handle it. Don't worry, sir. We are all young. We will handle it. Don't worry." And some nurses and doctors who are handling this, they said that initial days, even if we get infected, they decided we will come, get admitted, work here. Once we get infected, we will work continuously, because they said the second infection may not be there, so we will work here. So that kind of a commitment I found in almost all of our units, the doctors, nurses, other technical people, CT scan technician, ambulance driver, you name it, everyone had that kind of this thing. And in fact, we also reciprocated in a big way. We arranged accommodation, we arranged 100% free food for all the staffs for a very long time. And we didn't sack any employee for first 6 months. After 6 months, we sacked few employees who never came to the hospital, though we had put duty for them. We never cut salary. We didn't do anything. So we had a very small amount of 60 people, after 3,500 people, we cut salary. Those 60 people were someone people earning more than 1.5 to 2 lakhs. The doctors also, many doctors voluntarily came for a pay cut, but we implemented it after a long time, but reversed it after 3 months and paid back whatever we have taken from them. So we realized that we have invested heavily on people, and that has worked very well for us. And for everyone, I think that is very, very important. People are the biggest asset. Please take care of them. They are going to work for you. They're going to be with you during the crisis. That's the biggest lesson which all of us learned. Technology is a great thing. Technology is something, say, we always see that many doctors are technologically handicapped. That's what I say. Many doctors are technologically handicapped. When we started our hospital in 1999 in Trichy, that's when I saw my first computer, actually. Before that, I haven't seen a computer. I've seen a railway station booking counter. Before that, I haven't seen a computer. But over a period of time, I became passionate about IT systems, and we have implemented a lot of softwares in our company. In fact, I started my own software company 5 years back, do a healthcare ERP systems, and very, very well-connected hospital we have. But that helped us significantly. But what has happened? See, I say that doctors use only one technology, that is called WhatsApp, actually. You see that they are not, most of them, some of them are in Facebooks or other things, but social media, but most of them are not in social media also. They don't have time, they're busy in their clinical practice, and they don't use many of the apps or other things. Even I'm handicapped with a lot of apps. My children teach me how to use the other apps, actually. So WhatsApp was the only technology which doctors were using, and suddenly it zoomed and everyone started using Zoom up to Zoom. Imagine today we are able to do this program. I'm able to sit in the comfort of my house and able to address many people. In fact, 1 hour before I was addressing another audience. So we are able to reach out to international audience or any number of people on Zoom. All of us did extremely well. IMA did an amazing job. A lot of interactions, a lot of CME accredited point seminars were conducted on Zoom with the comfort, with zero cost, near zero cost actually. So now we know that how we can use technology very fast, adapt technology, okay. One thing which this pandemic taught us is human beings can adapt to any situations if necessity arises. We never thought we can sit inside home for months together. We can tolerate our family for many months. We realized that we could do, and we realized that family is there. We also have a nice family. We can spend some time there. And we also realized that things can be done from home. A lot of things can be done from home. So adaptation is a very significant character of the human beings, which COVID has proved. And doctors are also very well evolved human beings. We can also adapt very well. So provided situation comes and we have the right mindset, we can adapt the changing technology, process and everything. People started doing video consult and telemedicine. Imagine telemedicine being there, work for 20 years. Apollo Hospital had done it long time back. We tried doing it because of regulations. We couldn't do it. Suddenly, within a matter of 10 days, government changed the regulation. Suddenly, they said telemedicine is possible. And a lot of platforms are there. People started doing video consult on Zoom or WhatsApp or anything. They use apps, not apps, anything. And a lot of patients came through to video consult. The patients were willing to adapt. Very surprising. And these are some things which they are also willing to learn. And of course, after once the pandemic is over, people started coming back, and in tier 2 and tier 3 town, the patients wanted to see physically. But in tier 1 towns, a lot of patients still want to do video consult. The same practice will slowly percolate to tier 2 and tier 3 town over a period of time. Telemedicine, video consultation, all those things have picked up very well, and it's going to be the order of the day slowly. Working from home, I said, is something very exciting. People like me who are doing administrative jobs. Earlier, I was thinking that I used to go to the hospital every day. Now I go to the hospital only once in a week, though pandemic is not there. I did 99% of my work sitting at home. We are well connected, actually. In fact, we have developed, we have implemented at a huge cost a lot of security systems in our IT, where we have given around 150 laptops to various employees before these things happen. And all of them access our servers sitting at home. Sitting at home, all my finance team, purchase team, everyone work from home. Backend team, except for the nurses and clinical team, the call center, you'll not believe the entire call center was shifted to the employees' home. People answered all the phone calls sitting in their home and redirected all those calls. These things helped us to take that remote. You will not believe, at one point of time, Chennai had peak of COVID. We didn't want our billing staff to get affected. We asked the billing staff to sit from home, and we did billing from Trichy for Chennai for some days, few days actually. And for 1 or 2 months, they started working from home, and the billing charts were scanned. It was accessed. IT systems were used. Bills were created. Bills were sent by WhatsApp and other things. They paid by Paytm, and so many things. Online payment was done. So working from home is an exciting opportunity for doctors, for some doctors like dermatologists and all those things. People, even today, they can work from home wherever you need not physically touch patients on a daily basis, or follow patients, post-surgery patients, follow patients can do teleconsultation, which you can sit at the comfort of your home and do it actually. And also, very interesting thing happened in remote monitoring. Remote monitoring is something which we have been trying to implement solutions last 15 years, but we are not succeeded. Even now, we are experimenting with 4 solutions where the patients are connected to IoT-based devices, where the monitors, ventilators, everything is taken online. There are a few solutions available which are very costly, but now in COVID, we experimented 3-4 solutions which are cheap and which is very good. Now we are going to refine it. This throws up exciting opportunity for clinicians or critical care physicians who can manage. Suppose you are there at home, you are managing a critical care unit, 10-bedded or 15-bedded unit. Suddenly, middle of the night, someone calls, sir, patient is sinking, the ventilator settings are not right. You just log into a system, you see that ventilator waveforms are not right. You say that you can detect easily that it's a airway obstruction. Please do a suction or change airway, you can correct it. These things are possible. We have done 1 or 2 things actually, 1 or 2 things already. So that looks very exciting for me. And if you use technology, we can connect our patients remotely. For example, pregnant patients can be connected remotely. All the partogram, everything can be done from the comfort of home. They can send it. Our cardiac patients, post-cardiac surgery, they can do a ECG, transmit via the mobile phone. A lot of things can happen. Everyone has got a pulse oximeter now, or glucometers. These will be connected to the mobile soon. And mobile companies are, Apple is coming out with a lot of such features. So remote monitoring of healthcare, suppose you have a senior citizen in your home sitting in some part of the country, you can attach some remote monitoring to them and you can monitor them remotely. So those are some exciting opportunities coming. So the lessons taught by this pandemic is technology is going to be part of everyone's life. It is not only your regular iPad or mobile or social media. It's the technology we can use in healthcare. For us, healthcare people think technology means MRI, CT scan. No, for me, technology is MRI, CT scan. No, it is the basic softwares you have or mobile applications. Connected healthcare is what I'm talking about, or teleconsultation kind of a thing, telemedicine. That is a technology. And also we realized how important is our diagnostics. Diagnostics is radiology, imaging services, laboratory medicine. Because we all know that diagnostics have improved our diagnosis, and early diagnosis and treatments have improved significantly in the last 20 years because of development of CT scan or imaging technologies. And of course, a lot of automated laboratory results. So now, if you see that the diagnostic companies' valuations are booming and a lot of companies are coming into play. And this we have learned, we knew that, but we learned that we have to invest in diagnostics, laboratory or radiology, invest in people so that early diagnosis, because COVID is not going to be the end. There are a lot of respiratory pathogens or other pathogens are going to come in the coming years. So we need to be we need to have a very dynamic and robust diagnostic department so that we will be able to detect diseases earlier and treat them appropriately. Another very, very important thing is importance of infection control practices. Infection control practices way back in 2002 or 3, I don't remember the year. So at that point of time, we started getting HIV patients. At that time, there was a lot of hype, and slowly India started getting HIV patients. We started seeing 1 or 2 patients, few patients in Trichy. At that time only we started a hospital. We are just one hospital. We didn't have enough expertise. So one day there was a seminar from CMC where people came here, did a fantastic workshop in Hotel Sangam. I was part of the workshop. They taught us very clearly about how to handle HIV patients. How to handle HIV patients, they taught. and they taught about hospital infection control, HICC. Actually, that was the first time I heard about all these terminologies. And when I went back to CMC, stayed there for 2 days. I knew a microbiologist who helped me to learn things there. And then I started adapting practices here. Then when I became an NABH assessor, NABH insists a lot on infection control practices. I visited various hospitals, copied the best practices, implemented in our hospital. So we have been teaching infection control practices to every nurse, every situation, could be ICU, ward, or theater, name it, everywhere we teach them how to wear a mask, or respiratory pathogen, or bloodstream infections. We have been teaching them, and they are very well versed. Everyone, it has become a part of their work, it has become part of their culture. This helped us to tackle this pandemic because our nurses and doctors said, okay, sir, it's like any other respiratory pathogen. Probably infectivity is more. Actually, if you take swine flu, the mortality is high in swine flu, infectivity is less. Here, infectivity is more, mortality is less compared to swine flu. So, infectivity, of course, we'll use N95, we'll use the aprons and other things, hand washing, hand hygiene. I think that will. So, hand washing, hand hygiene, and mask help to save our staffs and doctors and gave huge confidence. I think we have been trying to get doctors follow this hand wash and hand rub techniques with great difficulty, but suddenly everyone started doing it. We are really happy to do it. With this, probably hospital-acquired infection or such kind of a pandemics can be easily tackled. I see that there will be a significant drop in hospital-acquired infection as we go forward because all the clinical team members will continue this practice at least for some more time. So we need to ensure that infection control practices, let it be a small OP clinic or a small hospital or a big hospital, with ICU, without ICU, theater or no theater, infection control practices are very, very important because we are going to see more and more of these pandemic because we have slowly, human beings have invaded into nature and the organisms are going to take us for a ride, actually. That's what I feel, actually. The another thing which we learned is about digital space. Digital space is a very interesting space, actually, which most of us are not there. Digital space is something huge. We are not there. Suddenly, what happened? We are at home. We have cut down marketing costs. Patients are not coming to the streets. So how do you do it? How do you reach out to the patient? Then when we started looking into Zoom seminars and other things, we realized that we can take a lot of public awareness seminars using Zoom, Facebook, Insta Live, you name it. There were YouTube videos, everything. And suddenly we found that there are enough opportunities. I think in Kaveri, in the last 1 year, we have done close to around 60 to 70 Facebook Live sessions for the patients. Amazing reach, amazing feedback. And we have done a lot of webinars for doctors and nurses on the digital platforms, Zoom or other things. And we started focusing on digital space, Facebook, LinkedIn, or your Instagram, YouTube's, websites, so many things. When what generally we say, no, those things are for bigger hospitals. We don't have that kind of a budget. And you'll be shocked to see that we have spent 1/10 of our normal marketing cost for this digital space. Any hospital can do. 90% of this digital marketing is free of cost. Only 10% you have to pay. 90% is free of cost. All of us have to be in digital space. It's so cheap. It's you can reach. You cannot say that no, my patients don't see that. No, everyone now sees Facebook, WhatsApp, or whatever it is. And you have to be digital based. You're a small hospital, big hospital. You have to be there. I think yeah, you need not worry. You cannot say that I don't know digital space. You go back to your children or grandchildren who are just 10, 15-year-old. You say that, set me up a website, set me up a Facebook page for my hospital. In one day they will do, and they will do a digital marketing for you. You need not do anything. They will do for you. I think that is a very interesting lesson for all of us, actually. Then the last thing of my this thing is collective bargaining. I've been a proponent of this particular thing for the last 15 years, but somehow I didn't get the right kind of encouragement from other medical communities. So I left it. That's one of the reasons why I started my exhibition. What I thought is a lot of medical equipment companies are taking smaller hospitals for a ride. And so I thought that if all of us pull in our resources, if you do a collective bargain, we should be able to extract better things from all these companies. Way back in 2004, I just asked few of my friends, can we do a collective bargaining? They were a bit skeptical. They said, no, no. At the time, I mean, even Kaveri was a small brand, so they didn't trust me. Then I went back and started Medicall, and this exhibition gave me a huge visibility. After that, I've given many lectures about this to various forums, IMA and Nursing Home Board, or many things. But still, a lot of people are not convinced. But what happened in this COVID, the IMA went to the companies, bargained the price of all these N95 masks. Collectively, they said all the PPEs were difficult to source, so many things. They did a collective bargaining. They got a very good rate and they distributed it. Okay. Together, everyone achieves more. That is what STEAM is all about, actually. And we are a very big community. Doctors community is a very big community, educated community, professional community. If all of us come together, pool in the resources, and then bargain, need not be bargain, it's collective efforts if we take. And then the cost to individual hospital will be less. We learn from others' experience, and all of us can thrive together. I think that is one of the very key lessons which we have to take as an association. Could be APA, ISA, or whatever it is. From Indian Society of Anesthesia, they were just giving face shields and masks, actually. They bargained. Getting a face shield was so difficult those days. They arranged it. The companies listened to the association and the big groups. I think that's one of the very big things which we have to learn from this. Apart from this, I think that, say, doctors were, if you take the US, the drug companies charge heavily. So in American public hate drug companies, but they love their doctors. They think that doctors are good, drug companies are bad. In India, what has happened is the reverse has happened. There are too many drug companies out there, so people don't hate them. But doctors, they hate. They think that they are charging more or going in a big cars and other things. But that credibility is back today. That credibility is back today, mostly. I mean, of course, except for one or two incidents, mostly the country respects. Even our Prime Minister, 2 years back, he went to UK, and in a public forum, he spoke bad about the Indian doctors. But this year, at least, he changed his mind. And then he said that doctors and nurses are the pillars of the country. So now it is an opportunity for us to maintain that credibility and use it for the betterment. And the other thing is, when I talk to the smaller hospitals, they think that what will happen today to the businesses, to our practices, other things. The second wave, we are talking about Maharashtra and other places. We are yet to see, but say at one point of time, we had 450 patients or 500 patients across our hospital, COVID patients. Last month, it came down to 30 across our hospital group. We had 30. But as of today, we have around 60 patients. In the last 1 month, slowly, steadily, it is increasing. But when the conditions, the outcomes are very good nowadays. So I don't know whether we are going to get a second wave or lockdowns or something. But in the long run, the health-seeking behavior of the public is going to improve. There is going to be a lot of insurance. Imagine a lot of people took COVID coverage policy. They will extend it. Insurance will be there. And they will come to the hospital. Actually, they will come to the hospitals. And probably they may afraid to go to bigger hospital because they think that they can get infection from bigger hospital. They will go to smaller neighborhood hospital, family physicians. I feel that there is an immense opportunity for small and medium hospital. The small and medium hospital segment is what I'm very passionate about to support them, because we were very small, we became medium, now we have become a big hospital. But I think that small and medium hospital gives a last mile connectivity to everyone in the system. They deliver healthcare to remote corners of society. Today, Tamil Nadu or Kerala, whatever it is, because of the private hospitals, private doctors who went to smaller towns and delivered healthcare. Any kind of support from us will be done. I think that this collective mindset has to be there, a positive mindset has to be there, and a professionalism, yes, adaptation. We can adapt to any change. Adapting technology or newer practices has to be there. And if you have that, All of us have got a great future. And I was just telling my children, both my children have not taken medicine. That I told them that very clear. This is the situation where when you become a doctor, when you join medicine, normally we do it with very high ideals that you want to serve the society. It gave us an opportunity for me and my team to serve this places where we serve. All of us did a great job in our areas of expertise. I think we'll maintain the credibility, and there is a great future for doctors and small and medium hospitals. That's what I learned. Thank you everyone. Thank you everyone.
Thank you so much, sir. Thanks for that enlightening talk. The floor is now open for discussion. And if anyone wants to talk to the speakers, they're most welcome to.
Can I speak, Shakti? Is it possible?
Yeah, please, sir. Sure.
Yeah. Sir, that was a wonderful lecture, sir. Good afternoon, sir.
Thank you, sir. Thank you.
Yes, sir. Yes, sir. You have shared all the experiences, what we did it, what in our hospital, what we did it, and what the success story was for the past 1 year. One thing I just wanted to tell, before this pandemic and all, we were very much worried about, very much insisting upon hand washing to every doctors, every nurses and all. But this corona totally changed, and we need not ask them to do a hand wash. Automatically they did everything. It went on in our own. So that was one point I just wanted to tell. And the lot of these term insurance guys, term insurance representatives, no calls from them for the past 1 year or so. Anyways, that was a nice lecture organized by IPI Trichy. Thank you. Good afternoon, sir.
Hello, sir. So let me try to summarize what sir had said. I've always looked towards hearing a lecture from sir for a long time. Right from medical, I've always been enthused by that fact of the idea behind medical. So basically, sir spoke about financial prudence, how a good cash reserve and being proactive could be the game changer. I think that was something which hit a lot of people hard. They didn't expect anything, and therefore they were not ready with their finances. And second thing was on credibility and looking into the patient's cost control. That was something I thought was usually the other way around in hospitals, but in a tier 2 city, that's a very important thing as to looking into patient's cost control. And of course, clinical protocols are part and parcel of every hospital, and the tariff system again is there. But then the importance of team building and this very important thing on nursing and how it is the key to how a hospital works, and why nurses should be nurtured, and how we should have a system of we should be able to have our own supply chain of nurses, and also creating quality in them, which I had seen in CMC, and I see Kaveri doing the same, of having their own system of bringing in nurses and then training them and then putting them into the system. So that's a very good thing. And technology wise, again, I have been admiring sir for a long time. As sir says, he's also doing a software company, which I didn't know. But again, from medical, the idea of having so many, I mean, it's a huge idea. Basically, having so many market players coming into our country, and then bringing in the doctors in. It's a direct one-to-one, which was made possible because of this idea. So again, kudos to you, sir. And then embracing change, which is adaptation, which sir said. Telemedicine, of course, and he said it will become the order of the day. And I also hope, especially in a specialty like mine, where we can do it from home when it comes to thyroid disorders and all. Telemedicine is something I'm quite excited about. And I don't think that the government will go back saying telemedicine will no more happen. I don't think they'll go back on that. Remote monitoring, as sir said, I have some of my endocrinology friends here as well. Dr. Matthew John from Trivandrum. Sir is a pioneer in remote monitoring for diabetes. So remote monitoring is something which we were always looking into as far as remote diabetes control is concerned. And that is something also, again, because of the adaptation of the public towards technology, that I think is possible. Importance of diagnostics as a clinician, that is something which is very dear to us, and Hari will also agree with the same, being a diagnostic person. And making good practices a part of team culture, something which sir said. Good practices as like washing hands and so many other things which we thought were just things which were ideal, now have become a part of the team culture. And lastly, on digital marketing and how we should have short, medium, and long-term goals, and how the future looks bright for doctors in these small hospitals. So thanks again, sir, for this wonderful lecture.
Thank you, Sakthi. Thank you, everyone from APA members. Thank you.
Anyone else who wants to ask a question?
During 2001, சாரும் நானும் மொபைலில் பேசிகிட்டு இருப்போம். அப்போ கேட்டிருக்காரு, நானும் கேட்டிருக்கேன், சார் நம்ம பேசிக்கிட்டே இருக்கும்போது அந்த நோக்கியா 5310, it was Nokia 3310, 5310, that was a bigger mobile. So sir and myself used to discuss, phone பேசிட்டு இருக்கும்போதே கான்டாக்ட்ல யாராவது ஃபோன் நம்பரை பார்த்து சொல்ல முடியுமோ? That was our technological என்ன சொல்றது, birth at that time. During 2002, 2003, sir. Hope you remember, sir.
Yeah, I remember. I used to the bulk WhatsApp, bulk SMS every week joke.
In fact, Manivannan, I was utilizing your services in IMA to send SMSs, bulk SMS.
Bulk SMS. Nariya association I used to send support.
I used to take the help of Manivannan to send SMS throughout Tamil Nadu. I think that was one at the beginning. One thing I want to add, Sakthi and Manivannan and Senthil, is if you read yesterday's paper, the sanitization, mask and social distancing has probably made flu disappear in Western countries and probably to an extent in India also. The regular flu, they say, has disappeared in US this time. Because of the sanitizing, we don't know. And I don't know how much scientific evidence is. It's only a media report.
No, sir. Sir, what we see is there is a significant drop in admission of pediatric patients, actually. Okay.
Yes.
Of course, school is not open, but still, there is a significant drop in admission of pediatric patients. They say this is one thing which we have to learn. Regular general practitioner, I don't think he'll be getting flu at least for next 1 or 2 years, or all these things. Hand hygiene are going to be the part of the thing. The infectious disease, certain infectious disease will come down, certain things will go up. I think something, a paradigm shift is going to happen in this disease profile.
Senthil has helped us in the Zoom meetings and IMA, APA, all this, and I feel this Zoom is going to stay forever because it is advantageous. Now I'm in Chennai today.
Okay.
Now Sakthi sent me a reminder. Immediately I was with my friends in a hotel very close to the beach road. Came home, immediately switched on and started attending. So I think when I was in IMA attending meeting physically, my thoughts were in tea, biscuits, vandircha varliya, dinner vandircha varliya, biryani vandircha, chatti arangidicha. My thoughts are all there. Now I'm able to really learn something, focus. Whether in case I'm going to pray, video amount off, whatever you do, we are able to learn. This is knowledge. We are imbibing knowledge. Sitting at home, utilizing the speakers all over the world. I think the Zoom must stay. Even if there's a physical meeting, the Zoom must stay. I think that is going to stay also, even otherwise. Virtual meetings and telemedicine will slowly pick up. This is I think that this is the bottom line of what we have discussed today. And one அவர் சொல்லிட்டு இருக்காரு, காவேரி ஹாஸ்பிட்டல் ரொம்ப நாளா மணிவண்ணன் சொல்லிட்டு இருக்காரு, this bulk purchase of equipments, so that now we are at the mercy of the equipment companies. I think a day must come when we should probably able to dictate, buy together. Pulse oximeter 1000 வாங்கினா the price is going to be different. We can all share 5 each. இதெல்லாம் I think பேசிட்டு இருக்கோம், it's not taking place. I think Manivannan, I'll be happy if you give me a proposal. I'll send it to the IMA, all India level itself. We can have Jayalal is there, we can take up the project. கண்டிப்பா பண்ணணும் Manivannan. We are at the mercy. அவன் equipment supply பண்ணிட்டு afterwards the way he treats us ரொம்ப சிரமமா இருக்கு.
Sir, இந்த ப்ரோக்ராம் பண்ணோம்னா நம்மளுக்கு டெஃபினட்டா வந்து இந்த எக்யூப்மெண்ட் ஹெட்ஏக் வந்து 80% கம்மியாயிடும் ஃபார் ஆல் தி ஸ்மால் ஹாஸ்பிட்டல்ஸ். ஐ அம் வெரி கான்ஃபிடென்ட் we can do it. அது ப்ரொவைடட் அது அசோசியேஷன்ல இருந்து சப்போர்ட் கிடைச்சா மட்டும் தான் பண்ணணும்.
நீங்க ப்ரொபோசல் கொடுங்க மணி, நீங்க ப்ரொபோசல் கொடுங்க. I will carry it with me when I go to Delhi next time. Please do it. Please
Definitely.
Thank you Manivan. Thank you. God bless. Thank you.
Zoom பத்தி சொல்லும்போது one thing which I forgot to mention is இந்த எஜுகேஷன் வந்து நம்ம வந்து we will make it very robust actually. Basically என்னன்னா what we are trying to do, learning management LMS அப்படின்னு ஒரு பிளாட்ஃபார்ம் வந்து நாங்க ஒரு 6-7 years back நம்ம ஸ்டாஃப் எஜுகேஷனுக்காக ஒன்று கிரியேட் பண்ணோம். ஒரு நல்ல பிளாட்ஃபார்ம் கிடைக்காம கஷ்டப்பட்டோம். இந்த லாஸ்ட் 1 yearல all these struggles-ல we found a beautiful platform. நிறைய பிளாட்ஃபார்ம்ஸ் இருக்கு. And now what we have got 1,500 nurses, 3,500 various types of employees and technicians. So இப்போ என்ன பண்றோம், அந்த பிளாட்ஃபார்ம் வந்து மொபைல் பேஸ்ட் பிளாட்ஃபார்ம். அந்த பிளாட்ஃபார்ம்ல வந்து we are going to upload around 2,000 videos, small videos, 5-minute 10 minutes videos about small things. ஒரு ICD போடணும்னா எப்படி, வென்ஃபிளான் போடணும்னா எப்படி, இன்ஃபெக்ஷன் ஹேண்ட் வாஷ்னா எப்படி, இந்த மாதிரி நிறைய வீடியோஸ் கிரியேட் பண்ணோம். ஆல்ரெடி we have created 500 videos. அது வந்து ஒரு ட்ரையல் பேசிஸ்ல நடத்துறோம். இப்போ வந்து ஆக்சுவலா we will expand it. So all our employees can just open up their mobile. அவங்களுக்கு ஸ்பெசிஃபிக்கா ஜாப் ஸ்பெசிஃபிக் ட்ரைனிங் வீடியோஸ் they can see actually. So இதை வந்து கொஞ்சம் சிஸ்டமேட்டிக்கா பண்ணிட்டு இருக்கோம். இது பண்ணோம்னா what will happen, training will become classroom based training இல்லாம மொபைல் பேஸ்ட் ட்ரைனிங் மாறிடும். அப்படின்னா என்ன ஆகும், நம்ம ஸ்டாஃப் நம்ம ஹாஸ்பிட்டலுக்கு வராங்க, ஒரு 1 hour கிளாஸ் ரூம்ல வச்சு ட்ரைனிங், NABS ட்ரைனிங் பண்ணணும்னா ஏன் கிளாஸ் ரூம்ல வச்சு ட்ரெயின் பண்ணணும்? People can log into the mobile and do it actually. So இந்த ட்ரைனிங் வந்து we are going to do. Once this is refined, we want to expose this platform to every doctor or hospital. Probably we'll do it after a year so that everyone need not invest their time and energy on creating these videos and other things. Refine it, we just open to free of cost to all the hospitals and do it so that everyone can use that to train their staffs. Adan we are planning to do.
That's a wonderful thing, sir.
I think
a question to Hari as well.
Yes, sir.
Hari, you were saying about myocardial perfusion imaging,
Yes,
and you said it's a stress test. So how, I mean, the usual logic for a person is that the person already has a chest pain and then you are putting him on a stress test. How do you explain that, Hari?
Yes, sir. The patients with atypical angina, stable angina, they can safely undergo stress.
Okay.
Only in unstable angina, in less than 48 hours, it is a contraindication.
So these people வந்து usually வந்து அந்த cardiac enzymes நெகட்டிவா இருப்பாங்க.
ஆமா ஆமா ஆமா. Stable angina, like அவங்களுக்கு தெரியும் ஒரு, I mean, if they climb 2 stairs, they will start getting chest pain. 15 minutes நடந்தனா they will start getting chest pain. Stable angina and atypical angina, they can safely undergo stress. Only in unstable angina, when they are having mildly elevated enzymes, illa வந்து they are ongoing myocardial infarction, they are contraindications for stress test.
And right now you are talking about pheochromocytoma. இப்போ MIBG பண்றதுல gallium PET தான் பண்றோம். So MIBG is now phased out.
இல்ல, see, there are two main issues with MIBG. MIBG, first thing is availability.
Okay.
Right now வந்து இப்ப பார்த்தோம்னா the only place which is having regular supply is from Brit in Bombay. They supply sometimes once in 15 days or once in a month.
Okay.
While gallium is in-house.
Okay.
So patient walks in at 8 o'clock now, we can finish the scan by 10 o'clock.
Okay.
Second thing is that it is MIBG is labeled with iodine 131. Iodine 131 வந்து is a high energy gamma emitter. So we cannot give more activity for the imaging. So image or the quality will be poor. And second thing is the patient's radiation exposure will be more.
Okay.
But gallium, we can give a good amount of radioactivity and get excellent images. Patient radiation exposure is also less. So convenience, comfort, everything is in favor of gallium total.
Okay. So two more things. Hari, you are talking about GI bleed, how nuclear medicine can help us. Can you, I mean, elaborate more on that as to which are the cases which we can refer for a suspected GI bleed? Which are the cases which I should be referring to a nuclear?
Okay. Another, the definite indication is obscure GI bleed. Okay. So if a patient is having hematemesis and you suspect the origin to be the stomach or esophageal varices, that those are not cases for GI bleed scan immediately. So patient is having a stool occult blood and upper endoscopy is normal. So you're suspecting bleed from either from the small intestine or from the large intestine. Those are the cases that are ideal candidates for J bleed scan. Those who are having intermittent episodes of gastrointestinal bleeding, who would have had the previous episodes of melena, but other investigations are normal. Those will be the ideal candidates.
And the second thing is on renovascular hypertension, which you said. So usually what we do is renovascular, we do a Doppler, but they say Doppler again is not able to pick up most of the cases. So young hypertension, we always have this problem that once we rule out an arterial cause, we suspect it could be renovascular. So what are the indications? When do we send it for a nuclear scan?
Actually, there are two components in this. First is an anatomical component, which is the renal artery stenosis. The second thing is the physiological component, which is the renovascular hypertension. So a patient who is having a renal artery stenosis and also having hypertension, whether he will become normotensive after intervention. So that question will be answered by captopril scintigraphy. For example, if a patient is having a renal artery stenosis, he is having a positive captopril scintigraphy, the chances are that his hypertension will be cured after the intervention.
Okay.
But if he is having a negative captopril scintigraphy, the chances of he getting normotensive even after the intervention is less. So, the physiological consequence of the stenosis we can study using captopril scintigraphy.
Okay. So, thanks again, Hari. And I like the color maps of the brain which you showed me, yellow and all that. So, thanks. And any other questions? If there are no further questions, then I would request Dr. Ponnaya sir to kindly give the vote of thanks. We'll be felicitating the speakers separately directly later.
Good afternoon. This is a time to propose vote of thanks. Am I audible?
Yes, sir.
I thank Dr. Hari Shankar for his vivid lecture on nuclear medicine. In 70s and 80s, we know very little of nuclear medicine. A few isotopes and radioactive iodine for treatment of thyrotoxic. Now, as in other branches, nuclear medicine has made a tremendous advance, and the diagnostic and therapeutic aspects well explained by Dr. Hari Shankar. I thank him for his interesting and informative lecture. One of the valuable things we can do to heal one another is to share each other's experience. This is the scope of Dr. Manivandan's lecture. His lecture sharing his experience as anesthesiologist and administrator of a corporate hospital is very well informative. I thank Dr. Manivandan for his interesting lecture. I thank all those who attended this virtual meet. Hope we'll have a physical meet soon. Thank you, one and all.
Thank you, sir. Thank you, one and all. Thanks for being here. Thank you so much.
Thank you.
Thank you.